Hello, everyone. I'm Bob Gagel from the Department of Endocrine Neoplasia and Hormonal Disorders at MD Anderson. And I'm joined today by Mark Zafereo, who is from the Department of Head and Neck Surgery and an experienced thyroid surgeon, particularly in the area of medullary carcinoma. And our assigned topic today is, when should one consider tyrosine kinase inhibitor therapy for medullary thyroid carcinoma? So as I originally conceptualized this talk, I thought you would have already heard from Doug Ball and several other people about the use of kinase inhibitors and that this would be more focused. But then I discovered our location on the program means that you probably haven't heard a lot about kinase inhibitors. And in particular, for those of you who are attending the first time, it seemed to me appropriate to give a little bit of background. So let me move forward, if I can get it. So this slide gives you a historical perspective of medullary thyroid carcinoma. So I was an 8th grader when the medical profession first identified medullary thyroid carcinoma as being different from either anaplastic or poorly differentiated papillary thyroid carcinoma. Prior to that, it was one big gamish. And so the entire history goes back to about 1960. So that's about 60 years ago. During that period of time, there has been incredible progress in terms of understanding the disease. In the 1960s, multiple endocrine neoplasia type 2 was first identified as a distinct and genetic syndrome. Calcitonin was discovered in 1961, and the recognition that medullary thyroid carcinoma produces calcitonin was discovered at that time. The identification of large kindreds with multiple endocrine neoplasia type 2 led to the mapping of the MEN2 gene in 1987, and in 1993, the RET proto-oncogene was identified to cause almost all hereditary or medullary thyroid carcinoma, or MEN2. And the direct result of the identification of what we call a tyrosine kinase receptor led to the development of small molecules that inhibit the activation of the receptor and have been effective for treatment of tumors. So let me move on here. So medullary thyroid carcinoma is a malignant neoplasm of the thyroid gland, but it doesn't affect the follicular cells, those cells that are involved in papillary thyroid carcinoma. Instead, the C cells, or calcitonin-producing cells, are embedded or migrate into the thyroid gland during embryonic life, during fetal development. And you see on this picture to the right, C cells that are stained for calcitonin. And this came from a child with hereditary medullary thyroid carcinoma who had abnormal calcitonin values, but it shows you the location between the follicles of the thyroid and shows you that there aren't very many of them. In fact, this child has at least 3 times the normal amount in this section, so that normally they're present in very low amounts. The medullary thyroid carcinoma includes nesting of endocrine cells with an amyloid stroma, and I have not included a picture of that. Calcification of the amyloid, or the protein matrix surrounding the cancer, can occur and does often occur. And importantly, tumor markers include calcitonin and a second carcinoembryonic antigen. The most common sites of metastasis or spread of the tumor are to local lymph nodes, which occurs in approximately 60 to 65% of individuals who have a palpable, meaning a feelable mass in their neck. It can also spread to chest, liver, and bone, and does so frequently, and we'll show you some of that. calcitonin and CEA both, as shown in this slide, can be used as tumor markers. And what you see is that there is a slow upward march of both tumor markers over a period of a number of years. This is helpful because it gives us an independent way of looking at the disease, since when there are only low levels of calcitonin down in this range, we probably won't see anything radiographically or on X-ray. So it gives us some sense of where the disease is going and how fast it is growing. This slide shows in a schematic manner the difference between hereditary medullary thyroid carcinoma and sporadic medullary thyroid carcinoma. On the left side of the screen, you see a thyroid that has been sliced, and the small dots show the greatest concentration of C cells within the normal thyroid gland. And you can see in both lobes that occurs in the upper portion of each lobe of the thyroid gland. And in the hereditary form, or multiple endocrine neoplasia, what you see is that this is where cancers develop. And you can see that in part B of this figure. And sporadic medullary carcinoma, which is a DNA change that occurs in a single cell versus the abnormality being present in every C cell here, it occurs as a single focus and can occur anywhere within the gland. We'll talk a little more about the difference between those two. So this is an example of a surgical specimen from a patient with hereditary medullary carcinoma, and you can see that there are multiple different foci in the left lobe, with the greatest clustering in the upper portion. And in the right lobe, you can see that there is also clustering in the upper portion. That doesn't exclude the possibility that it would be present elsewhere. It's just more likely. So the identification of large kindreds with multiple endocrine neoplasia type 2 led us to work with geneticists to map the causative gene for this disorder. And in 1987, the gene was localized to centromeric, or the center of chromosome 10, shown here in red. And over the next 6 years, there was a gradual march toward narrowing to the proximal 10q, which is down in this region of the chromosome. Then in 1993, it was narrowed to a 500 kilobase region. And in 1993, there two groups identified the RET proto-oncogene as the causative gene. This is a tyrosine kinase receptor, which is a fancy term for meaning that this protein, which you see several different portions, fits into the plasma membrane of the cells that express it, and activate a series of signaling proteins within the cell. And in the case of MEN2, and we'll just move to the next slide to make that point. So this shows you how RET inserts into the membrane of the cell, or the outer wall of the cell. It dimerizes, or gets together with another copy of RET, and then together with another protein called glial cell-derived neurotrophic factor receptor alpha 1 generally. And with a ligand that I'm not showing here, it can activate the receptor, and that activates a portion of the receptor called the kinase domain. And the kinase domain interacts with a series of downstream proteins, including RAS, which is the next protein in the pathway. The drugs that we're talking about today, tyrosine kinase inhibitors, work by blocking the addition of phosphate to the receptor, and thereby leading to inactivation of the receptor. The net effect of that is that it can stop growth of the cancer cell and also can promote cell death. Now, what we have learned since the discovery of the RET mutations or DNA changes is that RAS can also be mutated. It's immediately downstream. And at the present time, we do not have good treatments for RAS mutated tumors, despite the fact that they account for somewhere between 15 to 40% of all sporadic medullary thyroid carcinomas. So the other good news is that as the abnormalities in RET have been discovered, it has been shown that they also play a prominent role in several other neoplasms. And this slide shows that the RET abnormalities were first identified in papillary thyroid carcinoma, then, as we're talking about today, medullary thyroid carcinoma. But importantly, in 2012, it was identified that there are rearrangements of RET that occur in lung cancer. And for our field, that was big, because there are, unfortunately, a lot of people with lung cancer. And even though these abnormalities account for only 1 to 2% of all lung cancers, the fact is there are more patients with that 1 to 2% accounts for more patients than all of the patients who are diagnosed with medullary thyroid carcinoma in a year. So suddenly the pharmaceutical industry woke up and said, this is interesting. We need to get involved. And what has happened over the last couple of years is that there have been at least 2 new drugs, and there are others in the works that have come out. And the reason for that is, and I'll just say it, is greed. Greed is good. The pharmaceutical industry see a huge market in lung cancer and these other tumors. And so therefore they're spending money to develop better drugs. And the good news is they've been successful. So let's get to the focus of today's talk, and that is what are the treatment strategies for medullary thyroid carcinoma, and when should we consider the use of tyrosine kinase inhibitors? And so I've put here sort of my reasons for wanting, for how I approach a patient with medullary thyroid carcinoma. And as Mark will share with you, the primary therapy for medullary thyroid carcinoma is 98% of the time surgery. And the reason for that, prior to the kinase inhibitors, and even after the kinase inhibitors were introduced, we wanted to protect the airway, and surgery was sometimes curative. And we didn't want to miss that possibility. In a previous generation, certainly up until about 10 to 15 years ago, external beam radiotherapy was also used in patients who had extensive neck or mediastinal metastasis. And it was successful, or is successful, in reducing recurrences in the neck, but it had no impact on the overall outcome. That is, it didn't prevent spread of the tumor to lung, bone, or liver. And it therefore is used less frequently today, because we now have alternative therapies. And as Mark will point out, I'm sure, it makes subsequent neck surgery more difficult. And finally, the third modality, which we've had now since about 2011, 2012, is tyrosine kinase inhibitor therapy. And there has been a steady drumbeat of progress toward better drugs, which I'll try to very briefly go over. So this next slide shows you the signaling pathways that are involved in the genesis or causation of medullary thyroid carcinoma. You've heard about RET and its activation, and RET is mutated in nearly 100% of patients with hereditary medullary thyroid carcinoma, in approximately 50% of patients with sporadic medullary thyroid carcinoma. There are 3 other receptors that are expressed but not mutated commonly in medullary thyroid carcinoma, including the epidermal growth factor, a receptor called c-Met, and a third vascular endothelial growth factor receptor, and most commonly the second variant of that. And of course, RAS is also mutated in a subset of sporadic medullary thyroid carcinomas. So that sort of describes the landscape. Now, what drugs do we have? Well, the first to be approved in the early part of this decade were vandetanib, or its trade name is Caprelsa, or the second it was cabozantinib or Cometric, and they were the only two drugs up until about actually probably 6 or 7 months ago, when selpercatinib or LOXO-292, or its trade name is Retevmo, was approved. And the most recent approval, about a month to 6 weeks ago, as I recall, was Blue 667 or Gavereto. Now, a couple of points about these drugs. These are oral drugs that are generally taken once or twice daily, and they tend to be expensive. And these are not necessarily your costs, but these are what the pharmaceutical company is charging for each of these drugs. And I pulled these from our pharmacy this week to give you a sense that these are what people are screaming about, the cost of medicines. And this is about a $400,000 a year for these two drugs expenditure by your insurance company, and inevitably you're going to be paying some part of that. Suffice it to say that these drugs are effective, and we'll go into that very quickly. And I'm going to skip through this and just make the point that the drugs are effective. And this shows the phase 3 trial for vandetanib, which shows that about half of the patients had a 30% or greater reduction in the size of their tumor when treated with vandetanib. For cabozantinib, there were similar results, with about half of the patients having a 30% or greater reduction in tumor size. Now, the second generation, the two that were just approved this year, LOXO-292 or selpercatinib, and the other is Blue 667 or pralsetinib, are unique in that the first generation target several receptors that I showed you on the slide, whereas these target only RET or almost entirely RET. There's a little spillover into other receptors. And as a result, they tend to be cleaner. That is, they are slightly more effective, and without question, they have fewer side effects than the first generation drugs. So yes, so these show the data, and you can see that more than 2/3 of patients had greater than a 30% reduction with the Blue 667 or pralsetinib, and a few patients had their tumor completely disappear. Whether that will be a long-term disappearance, we do not know, because this has moved so quickly that we don't have follow-up. And for selpercatinib, there's a similar story with about 2/3 of patients responding, and even a bit higher for RET mutant medullary thyroid carcinoma that has not previously been treated with vandetanib or cabozantinib. So what criteria do I use for making a decision to treat someone with a kinase inhibitor? Well, the first is the tempo of the disease. That is, how fast is it moving? Is it likely to cause death or serious disability if we do nothing, sit on our hands and watch? The second is and other symptoms related to the tumor. And the third is location. I'm getting a message on my computer that The internet is, I hope that you're hearing this. Mark, nod your head if you're hearing. Okay, good. Or seeing it more correctly. The third is location. So if one has a medullary carcinoma that's metastatic to the spine and it's in danger of compressing the spinal cord, or if one has unresectable disease that threatens the airway, or if there is brain metastasis, one would of course treat it with XRT, but one would consider treating it. So I'm going to turn the floor over to Mark at this point, and I'll get out, and I've stopped sharing, so you can run it from your end, Mark. And then we'll move into some cases.
Okay, are you seeing my screen here?
Yes.
Okay. So I am Mark Zafereo. As Dr. Gagel introduced me, I am a head and neck surgeon here at MD Anderson Cancer Center. I am going to spend the next 20 minutes or so talking about some of the issues around surgery for medullary thyroid cancer, and particularly toward the end of the talk, how that relates to tyrosine kinase inhibitors. I do have some research funding for clinical trials from Eli Lilly and Merck, and a medical advisory board for Eli Lilly. And I guess I first wanted to just say what an honor it is to be on this co-host of this panel with Dr. Bob Gagel, who really is a legend when it comes to the treatment of medullary thyroid cancer. There's not a person in the country who knows anything about medullary thyroid cancer in terms of physicians who doesn't know the name Bob Gagel. And so just an honor to be with him and really continue to learn from him in terms of this disease. And you can see he does very well in terms of his patients. He has 5 out of 5 stars. So you should really come and see him if you haven't already. So just real briefly, stepping back as Dr. Gagel did, I kind of want to just give some brief background. Most of you all already know all this, but I want to give a few introductory slides in terms of how we think about medullary thyroid cancer. And as Dr. Gagel mentioned, most of the time upfront surgery is the treatment of choice for medullary thyroid cancer, and that's a total thyroidectomy and removal of the central compartment lymph nodes. Those are these level 6 lymph nodes here, right around the thyroid gland. But there is another approach to that. The Japanese have published on their experience when you look at sporadic medullary thyroid cancer. And this is an important distinction because, as Dr. Gagel so nicely showed in his presentation, the hereditary or germline mutated medullary thyroid cancers, which only make up about 20% of medullary thyroid cancers, are very often multifocal. And so you wouldn't want to select this treatment strategy for those patients, but for those who are not germline mutated, for those who are sporadic medullary thyroid cancers, and this is the cohort of patients described here that was published a couple of years ago in the World Journal of Surgery, we do see that that these patients can do well with just removing half of their thyroid gland, the so-called lobectomy, and unilaterally removing the lymph nodes around the thyroid instead of doing that on both sides. So I think that is an option for some patients with sporadic medullary thyroid cancer. It's important to realize that there's still, this was a study that was published from the California Cancer Registry a couple of years ago. It's still interesting to note that only 1/3 of patients underwent a central compartment dissection with their medullary thyroid cancer surgery. And some of that is due to that these were not known medullary thyroid cancers before surgery, which then again, that presents a problem because we shouldn't have 2/3 of patients where we don't know the diagnosis of medullary going in. So there could be some opportunities for improvement in some settings in terms of the diagnosis going into surgery. And then also I think there is opportunity for education, even amongst those physicians who are practicing about the sort of the standard of care treatment for medullary thyroid cancer being the removal of the thyroid plus the lymph nodes. And we also oftentimes, when we're talking about treatment of local regional disease for medullary thyroid cancer, we talk about the lateral neck. And that's the secondary lymph node basin, not the central lymph nodes, but the lymph nodes that are out to the side here, a little bit further away from the thyroid. And we break those down into levels of the neck. And so when you do a lateral neck dissection, in this picture, here's the thyroid gland here, and these lymph nodes can metastasize most commonly to these level 3 and level 4 areas, but they also can metastasize to level 2 and level 5. So you most commonly remove comprehensively all of these levels 2, 3, 4, and 5 lymph nodes when you're doing that type of surgery. We know that medullary thyroid cancer is a relative rare disease when you compare it to papillary. We know that medullary thyroid cancer does have a higher incidence of central lymph node metastasis, and that's why we typically do the elective central neck lymph node dissection with medullary. But what about the lateral neck? We do not do elective lateral neck dissections for differentiated thyroid cancer, that is papillary cancers. But there has always been some controversy about this idea of an elective lateral neck dissection for medullary cancer. And that's because about a third of patients with medullary cancer can present with lateral neck lymph nodes. And so it's a little bit more common in that group. And so some people would ask the question, well, why not do a lateral neck dissection or a bilateral neck dissection on every patient with medullary? And so in the guidelines, the American Thyroid Association guidelines, which last came out in around 2015 and will be updated probably in the next year or two, there is some room for debate. There's some suggestion that if you have a calcitonin of over 20, that you consider an ipsilateral elective dissection, and we'll talk a little bit about that data. In calcitonin over 200, you consider a bilateral elective dissection. And that's because there's been some data, and I guess the most prominent data has come from Germany, that have shown that once you get to that level of 20, is you start to see the central lymph node metastasis. And then once you get to this level of 200, you start to see once you get to 20, you start to see the ipsilateral central and lateral neck metastasis. That's in the blue box here. And then once you get to 200 in the green, you start to see the contralateral, meaning the opposite side of from the cancer, from the thyroid cancer, you see lateral neck metastases. And so, but we always have to consider as surgeons and doctors treating this disease, what is the morbidity of these lateral neck dissections? Many of you listening to this presentation probably have had a lateral neck dissection for medullary thyroid cancer. So it is associated with some aches and pains. And when we look objectively at what the morbidity of that, this is from a high volume center. This was highest volume surgical centers in Canada, in Toronto, and they looked at about 60 patients, and there was quite a bit of morbidity, meaning complications and even a little bit of mortality associated with patients who have a bilateral neck dissection with thyroid cancer. So I think it is important to note that there is some morbidity associated with that procedure. And then what happens to patients with medullary cancer whose lateral neck compartments are observed, meaning they don't have the lateral neck dissection up front? And so we studied this disease, we studied this scenario a couple of years ago, and we did find similar biochemical cure, local regional disease status, and distant metastasis and survival amongst patients whose lateral neck was observed compared to those who were dissected with similar calcitonin levels. And so, we do advocate typically that it's appropriate to observe lateral neck compartments in patients with negative lateral neck lymph nodes on high definition ultrasound and CT in many cases as well. One of the things that's this is an area where I think we've done some study. Is that what are the primary drivers of survival in medullary thyroid cancer? And it's typically the distant metastases that almost always drives the mortality. This was a study that we did that is yet to be published, looking at this data, and found that distant metastases, and oftentimes it's this percent change in CEA level, which is one of it's an antigen, one of the markers, blood markers that you can use to measure potentially measure medullary thyroid cancer. And that's often this distant metastatic disease, and as measured as this percent change in CEA can be a measure of or a predictor of survival. And so we looked at this recently, and again, this is yet unpublished data. Hopefully it will be published soon, but we looked at the staging system for medullary thyroid cancer. And as you probably all know, with any cancer, one of the questions we always get from patients is, what stage am I? And so for medullary thyroid cancer, there's 4 stages, and there's 1, 2, 3, and 4. And so those correspond to, 1 is here in the dark blue line, 2 is this line up here, 3 is this green line, and 4 is this orange line. And what you see is the survivals don't line up really neatly for medullary thyroid cancer. And that's because maybe the staging system isn't the best for it. One of the things, this AJCC cancer staging system was just updated a year or 2 ago for all the cancers, including medullary cancer. And one of the things we see is that there weren't any changes, and that it's really about the same as what you see for other types of thyroid cancer. So for papillary cancers and others. And so there may be some room for improvement in that in the future. And what we found is that these the percentage change in calcitonin and CEA, when you compare from pre-surgery to post-surgery, was actually a much better predictor of survival than the stage. And so I think that's something that we may see going forward, incorporated into the staging system. Another point I wanted to make that Dr. Gagel mentioned was with regard to radiation therapy, and this was a study that was actually published in the mid 2000s from the MD Anderson group, and it showed that radiation therapy is typically effective for controlling local regional disease and medullary thyroid cancer, but that it doesn't typically affect survival. And so at that time, there was a more liberal approach, and Dr. Gagel mentioned this in his talk. There was a more liberal approach to radiation therapy, and this was really only 15 years ago, 15 to 20 years ago. And then at that time, it was indications for radiation included presence of gross or microscopic residual disease, soft tissue extension, nodal disease, which is very common in medullary cancer, and mediastinal involvement. And one of the things that we have, I think, have moved a lot in the last 5 to 10 years is this much more conservative approach when it comes to radiation therapy, and a general trend away from radiation therapy, except in older patients with disease invasive of the esophagus or laryngotracheal complex. And otherwise, we've typically avoided it. And these are sort of examples of patients in the last 5 years. This was a patient 5 years ago who we treated, who had a lot of nodal disease. We treated him with surgery, no radiation therapy. And this is another CT scan. All of these little dots here are nodal disease. This is the trachea here, and you see a lot of disease that's very intimately associated with the trachea, and a lot of lymph nodal disease, mediastinal disease. And these are all no longer indications for radiation therapy in our practice, unless there is tracheoesophageal invasion typically, and then it's considered, although it's not always given even in those situations. And one of the reasons that for this change is because now we have other treatment options, and Dr. Gagel mentioned these. Vandetanib and cabozantinib were FDA approved in 2011 and 2012. One of the things I wanted to mention about these drugs, specifically from a surgeon's perspective, is that they have a lot of what's called anti-VEGF receptor activity. And that's how they work to treat these tumors, that they kill the blood supply to these tumors. And you can see that in terms of the activity here with vandetanib and cabozantinib as compared to some other tyrosine kinase inhibitors, very high anti-VEGF activity. And what that means is that these drugs also have some other potential effects. And Dr. Gagel talked about this a little bit, about the side effect profile of these drugs, and perhaps that these newer drugs available have a better side effect profile. But the cabozantinib and vandetanib, surgeons get a little bit more nervous about operating immediately before or after these drugs. And so typically these drugs have to be held for a longer period of time before or after surgery, because there are potential issues with fistulas or increased bleeding or wound healing issues. And so Dr. Gagel also mentioned the newer drugs that have just been FDA approved, the selpercatinib, which was for lung and thyroid RET mutated cancers, and the pralsetinib, which was only for lung cancers, but we know that this is being used in clinical trials still for RET mutated thyroid cancers. This is the Loxo in the blue. And this is based on the understanding that even for patients who are germline negative, that means they do not have a hereditary form of medullary cancer. Many of these patients, almost half of them, still have a RET mutation. And so one of the things I wanted to mention in the last couple of minutes before we get into cases is sort of a new treatment approach that we have considered in a select group of patients, and this is not in perhaps the majority of patients who present with medullary thyroid cancer, is that sometimes we can give upfront treatment with these new RET-specific inhibitors, and then follow that with surgery afterwards instead of the surgery up front. And that's because these new RET-specific inhibitors, as we mentioned, have very little activity against the VEGF receptor. It looks like they have a lower side effect profile in terms of what's been recently published in the New England Journal of Medicine article that was recently published, and others that will be published in terms of the clinical trial experiences. And so in this last point, possibly improve safety with surgery, that we haven't really proven that. We don't really know that, but we think that that could be the case. And so we also know that with medullary cancer, distant metastasis almost always drives survival. We know that neoadjuvant therapy may help some unresectable tumors become resectable. And that's because we're seeing, as Dr. Gagel mentioned, 50–60% responses in a lot of patients. And it also that this therapy may decrease the morbidity of surgery in some patients. And so, so I wanted to briefly show a case, and this is a case that we, and then after we show this case, we'll get into Dr. Gagel, I think, has 3 cases to present. But this is a case that we recently published in Head and Neck and is currently in press. And it's in regard to a 20-year-old, so a younger gentleman who presented with a sporadic and non-hereditary medullary thyroid cancer. He had a high calcitonin of over 10,000. He had some distant metastases to his bone and lung and liver. The lung and the liver and the bones being the most common areas of distant metastasis for medullary thyroid cancer. And so when we look at his CT scan, he had a pretty small tumor in his thyroid here in the upper left corner. But then if you look at his lymph nodes, he had pretty big lymph nodes in the neck. And this is a lymph node around his subclavian artery, about 270 degrees around the artery. The artery is there in the red arrow. The tumor is in the yellow arrow. And the same thing here in his chest. This is the big artery that goes to the heart, the aortic arch here, and a big tumor around it. And the problem with that tumor around there is that's also where the recurrent laryngeal nerve, which is the nerve that controls the voice box on that side, also travels. And so that was a problem for us. This patient did have a RET somatic mutation. Again, this is a mutation in the tumor itself, not a hereditary germline mutation. And so we gave him selpercatinib, and this was on a single patient clinical trial that was approved through Loxo Oncology at that time, and also the FDA. He got radiation to the spinal metastasis, and he had significant improvement in his visceral distant metastasis, the liver and lung metastasis with this drug. You can see his calcitonin dropped precipitously from 16,000 to around 2,000 with starting that drug, which is consistent with what we see. And then you can see the tumor shrunk considerably. So on the left, you see the tumor nearly encasing the subclavian artery. And on the right, you see a much smaller tumor as indicated by this. I mean, I would say this is 3 times smaller here. And so this frees up this artery and makes that surgery much easier. And similarly, when you see the same thing in the chest, this is the aortic arch, again, aortic arch here on the right side. And this tumor is about half the size here. And so it really helps it to move it away from those critical structures like the nerve there. We ended up doing his surgery after treating him with selpercatinib for 6 months. He did very well, removing a lot of lymph node disease. And we see that what happens with this is that, and many of you will experience this if you ever have gone on this drug or do go on it, you see a significant drop in his selpercatinib initially. And then when we hold the drug for about 10 days, we can do a relatively short drug hold for these patients because the drug is, we think it's very safe to be used in association with surgery. It still causes a bump in that calcitonin. And then afterwards, the surgery, you resume the selpercatinib, and then now his calcitonin is almost zero. It's around 50 or 60, whereas it started in the 13,000 range. And so this is a sort of a combination strategy of neoadjuvant therapy with the RET-specific inhibitor admixed with surgery, and it's an approach that needs to be studied. And this is a clinical trial that we're going to be leading from MD Anderson, and also involving 4 to 6 other centers in the United States, including Mass Eye and Ear, Harvard and Boston, Johns Hopkins, Memorial Sloan Kettering, to study this issue. And so we're leading that here at MD Anderson, and it's something that we definitely want to let our medullary thyroid cancer community know about, so that they can let new medullary thyroid cancer know about this potential treatment option. So surgery, this is my last slide, conclusion: surgery for medullary cancer in the modern era. We use high definition ultrasound. That's the mainstay of the preoperative workup. We do not recommend elective surgery for negative lateral necks in terms of the high definition ultrasound. Mortality from medullary cancer typically related to distant metastasis. We now have a much more narrow role for local regional radiation following surgery. There's now more effective targeted systemic therapies that we discussed, including the RET-specific inhibitors. And we're now studying this treatment approach of neoadjuvant therapy in the era of non-VEGF receptor-mediated targeted therapy. And with that, I am going to turn it back over to Dr. Gagel, who has some cases.
Great. Let me get back here. Share. Mark, can you see that?
Yes, we can see that.
Okay, let me get it into presentation mode. So I just wanted to say, Mark pointed out a fourth potential use for these drugs, and that is to take a tumor that is not resectable, to cause it to shrink, and then to follow that up with a surgical resection. This is a tried and true approach in oncology. For example, our sarcoma doctors almost always will treat a large sarcoma with chemotherapy for a period of time, with the goal of shrinking it to the point where they can get a complete resection of the tumor. And so we in medullary thyroid carcinoma didn't have drugs that were effective enough to attempt this previously, but as Mark has pointed out, it's a new world. People frequently do not talk about is the long term. And so I've chosen some cases where we have 6, 8, 11 years of follow-up of patients. And those of you who are dealing with this disease, I think it may give you both perspective and some hope. So let me move quickly to the first. And this is going to be, I identified tempo, the bulk of disease, and location. And of course, Mark added a fourth, which is shrink it so you can surgically resect it to it. This deals with the tempo of the disease. And this was a young man that I followed for some 15 years with multiple endocrine neoplasia type 2B, a very subtle case of 2B without the usual manifestations. And you can see on this slide, which shows his calcitonin, his CEA values, that his CEA after his primary surgery fell and remained quite low for a number of years. And then his disease exploded. And there became no choice. Up until that point, we just watched. And I think the important point here is that if disease behaves, we can't make you better. Most patients who have low amounts of residual disease are completely asymptomatic. And, and since all of these drugs have side effects and are breathtakingly expensive, we're not anxious to initiate them until we need to. So in this particular young man, his disease exploded and we put him on vandetanib. You can see that his serum calcitonin and CEA both fell very dramatically. He developed some side effects, so we dose reduced him. But what you see is that his calcitonin started to rise, and it actually then rose. It was clear that he was resistant. We tried him on cabozantinib for a short period of time, and unfortunately, a few months later, he succumbed to massive hepatic metastasis. So tempo would be an indication. Now, yes, there we go. This shows you that he did have a response. So this was his initial liver scan or CT scan. You can see that there was some progression here. And then after he was treated with vandetanib, there was a nice response with a reduction in the size of hepatic metastasis. Unfortunately, he did become resistant to both vandetanib and cabozantinib and succumbed. So that's the first example. And I think I've got a second case in here that illustrates that point also, but with a dramatically different outcome. But it highlights that while someone may have a calcitonin that is low level for a long time, there is always the possibility that the disease will change, that it will acquire new mutations or new DNA abnormalities. So that's first case. The second highlights location. So this is a somewhat complicated case of a currently 63-year-old white male who had no family history of medullary thyroid carcinoma. His primary operation for medullary thyroid carcinoma was in 1989 at the age of 32, when he had a total thyroidectomy, neck dissection, central neck and right lower jugular chain dissection. And all the nodes were positive. He subsequently underwent 2 neck operations for recurrent disease, the second of which was done at MD Anderson, and a recommendation was made for XRT. And following along Mark's discussion about this would have been standard operating procedure in 2002 because we really didn't have anything else that was effective. He then returned in 2009 at the age of 54 with recurrent paratracheal disease. And this sort of highlights what was our biggest problem. He has some other nodes, but I'm not going to focus on those. But he has this rather sizable left paratracheal node. And there was discussion at that point with one of our senior head and neck surgeons. It actually may have been slightly after this, about is this resectable? And as he was followed, this lesion continued to grow, and it became clear that the only way that one could get an effective resection would be to do a total laryngectomy. He was still in his 50s at that point, and was the sole support for his wife and his job. He would have had to give up his job if he could not speak. And so he made the decision emphatically that he would not undergo a total laryngectomy, which would have meant loss of voice. So as we continued to follow him, this grew even more, and this sort of lesion is concerning because it's likely that this is invading the wall of the trachea. And once he had tumor in the trachea, bleeding and bad things become a very real possibility. So we talked with him about the possibility of treating him with a kinase inhibitor at that point. And this was, you may notice that this was about a year before vandetanib was approved. And at the time, the next follow-up visit, vandetanib was available. Unfortunately, he fell into that trough between the last clinical studies being closed and the drug being approved, and the company was unwilling to provide it for compassionate use. And so we had to wait until mid 2011 before we could begin him on vandetanib. And the good news is he had a very nice response. And you can see that over the next several years, the tumor initially, this lymph node initially became smaller, and he had absolutely no symptoms related to the vandetanib, although he did have a development of a cardiac arrhythmia, which prompted me to reduce the dosage of vandetanib from 300 to 200 later in the decade. But you can see that he had a nice response. And then we got to the last couple of years, and this this shows the status in, I think it was 2018, but you can see the black shows the trachea. So we're looking at his trachea here, and you can see that this mass is manageable at that point. But as we followed him from 17, when it was still manageable, into 18 and then 19, it was clear that this mass was again enlarging. And it was this latter radiologic study that concerned me and Dr. Grubbs, his surgeon and primary physician. So the good news was that selpercatinib, which had been through clinical trials, at that point had not yet been approved, but it was available for a compassionate use protocol. And that is that a pharmaceutical company can elect to make the drug available to practicing oncologists or other physicians if there is a critical need. And in most institution approved drug. And the other problem we had, you will notice that this is about the time that COVID hit. Could not come to visit us, or would have had to stay. He would have had to quarantine, he would have had to quarantine for 2 weeks before seeing us. So his local oncologist was able to obtain selpercatinib and start it sometime in, as I recall, it was April or May of this year. And I spoke with him, well, let me just show you the other data. So this is, again, the longitudinal data going back to the late 90s. This was his reoperation done at MD Anderson. You could see there was a drop in both calcitonin and CEA, and he remained relatively low value numbers until this mass in his neck began to grow. And you can see both his CEA and his calcitonin rose at that point. There was a nice response to vandetanib, which correlated with the imaging studies I showed you. But, and we reduced him because of the cardiac irregularities, and he was doing quite well, but then his calcitonin and CEA started to rise, and that led us to look for selpercatinib. So this is an example of where we have given this man some time. Is this a success story? Well, his initial surgical treatment was in '89. We're now in 2020. So he's had a total of 30 years since initial therapy. He has kept his voice, which to him is very important. And we would classify this as a qualified success. He's had 2 CT scans done locally since I last saw him, and since he had one before starting selpercatinib and another one within the last few weeks, and he said there is some shrinkage of the tumor, and promised to send them to me. So we're considering this a qualified success story, but it may be necessary to see him. Now I see a raised hand here. So let me see if I can find a question. Yeah, I'm going to move on because we've only got 3 minutes left, and there is another case that I want to share with you. I'm going to skip over this one because it's another location example, but this is the 4th case is one where there was both tempo and bulky disease. This was a 37-year-old white female who underwent a total thyroidectomy, extensive lymph node dissection, and had 40 positive lymph nodes in 1998. She also received XRT to neck and upper mediastinum, which was our standard at the time. And this shows her calcitonin and CEAs. You can see that following her primary surgery done at MD Anderson, they came down very nicely, although they were never normal. And then you can see over the next decade, there was a progressive rise in her serum metastatic disease, but as we followed her, she popped up with bone metastasis shown on this slide. And this is her baseline CT scan. And you can see that there is no obvious metastasis in there. And then in 2011, you can see that she has many hepatic metastatic foci. So she has both bone and liver mets, had a few small lesions in her lung that we thought probably represented disease. So this was about the time that the vandetanib trial began, and so we placed her on to vandetanib. And what you can see is that her liver CT scan in November of 2010, about a year later, you're hard pressed to find. There are a few small little ditzels down here and maybe something there. So that we're pretty sure that she's not free of disease, but there has been a dramatic response. And this is from June of 2020. And you can see she has some calcified lesions. I mentioned earlier that medullary thyroid carcinoma, or the amyloid, frequently calcifies, and she has other calcified lesions. But, and there are some small other lesions, but remarkably, this has been an incredible story with stable disease now for 11 years. And let me just go back and show you, if you look at when she started on the vandetanib, there was a prompt drop in her serum calcitonin and CEA within a matter of months low since then. Now, we're not so naive as to believe that this is going to be in permanent remission, but this is a lady who I think we can safely say would not be with us today if it had not been for vandetanib. And so an example where there is a success story. Wish that they were all like this. So I think that brings us to the end, and I think we're out of time. But if there are questions, Mark and I are more than willing to stay for a few minutes and answer them. So Mark has been busily answering questions.
I tried to answer all the questions. Marilyn just asked a question about the little disease in liver can be treated with ablation. I hadn't answered that one yet.
Yes, and it is another technique. I have not been a big user of ablative therapies because what you know is that the ones that you can see are the ones that you treat, but there's almost always many others lurking in the background that are smaller and are going to emerge. And so I think our philosophy in that regard has evolved from, at one point we did ablate patients with medullary thyroid carcinoma and other metastatic neuroendocrine tumors. We have tended to get away from it in part because we're not convinced that there's value unless there is a systemic therapy that is capable of dealing with the disease you can't see. But that's our thinking about this, and there are others who may think differently, but there has been no good study to look at the long-term value of this sort of approach. There's no question that there are responses. Does it alter the long-term outcome is the question that we would ask.
Bob, I'll let you take this question. Is there anything out there for those of us who are RET negative?
Well, RET negative could be either a mutant RAS, and that certainly occurs in the context of sporadic medullary thyroid carcinoma. It turns out that both vandetanib, in the phase 3 trial of vandetanib, there was no requirement for a RET mutation, and the drug proved to have efficacy in patients who were RET negative. I cannot recall whether in fact, I think the same was true for cabozantinib, even though they were all typed. I don't think that it was a requirement for entry into in patients who have who do not have RET mutations. The second generation selpercatinib required a RET mutation to enter the trial. And so I don't think we have data on RET negative patients for that drug. Blue 667 did not require a RET mutation, and so some of them snuck into the trial. And I believe that there were responses. But I don't have that data at my fingertips now. And so whoever answered the question, if this is important to you, please send me an email at rgagel@mdanderson, and I'll find out what the data are. Now, I do have one patient with a RAS mutation who was treated with Blue 667 and had no response. His disease marched right through it. So what is available for patients with RAS mutations? Largely phase 1 drugs. And RAS, because it is the most commonly mutated gene in all of cancer, is currently receiving a lot of attention in the phase 1 world. And there are now drugs that are targeting RAS or targeting immediately downstream of RAS with the goal of trying to see efficacy. None of them, to the best of my knowledge, has been approved, although I have sent some patients to our phase 1 group for clinical trials. I think that's the best answer I can give you.
There's a question about evidence of patients on TKIs or Loxo that have had their tumors mutate as part of resistance. And I do think in terms of these clinical trials, there's been 1 or 2 examples of that sort of emergence of potential new mutations. But I think we probably need a little bit more data on that in terms of the new RET-specific inhibitors. Did you want to comment on that?
Yeah, Gilcoat and Naifa-Busaidi pulled together the data from our patient groups about 1.5 years ago, and I'm not sure if that's published, but it was presented at the American Thyroid Association. So the most common mutation that emerges is what we call a gatekeeper mutation, or codon 804 of the RET gene. And of course, neither vandetanib nor cabozantinib are effective against that particular mutation. So when resistance develops, they become basically unresponsive. The newer drugs, selpercatinib and pralsetinib, actually target those 2 mutations. And so there are examples of patients who, with 804 mutations or 804 mutations that have emerged, that have responded to this drug. And I think you see that in the data that I showed you for selpercatinib, where there were patients previously treated with either vandetanib, cabozantinib, or both, who then subsequently responded to selpercatinib. So, and it's an evolving field, and the numbers are still small, and I would say stay tuned.
There's a question about, will Lilly continue to provide Loxo free to compassionate use cases? And I think that they will for the time being. I think that there's also, for the time being, there's also going to be continued clinical trials. So for patients who may not otherwise have the option to be on these drugs through their insurance, I think clinical trials will be another avenue. That does require oftentimes going to a center, like MD Anderson, where we're running a lot of these trials. But that is another option that doesn't require your insurance company providing the drug. But I do think that Loxo will continue with some compassionate use cases. But I am not a Lilly. I'm not a spokesperson for Lilly, so that I cannot speak any more than that.
I can give you the experience with vandetanib. Once the phase 3 trial was closed, which was probably 4 or 5 years after it initiated, the company ceased to provide drug free to individuals who were on the trial. And for example, my patient who was on that trial and has been taking it for 11 years has switched over, and it's being paid for by her insurance. And I think that the same was true for cabozantinib, but I was not a part of that study, so I don't know the details. But and again, it's entirely up to the pharmaceutical company, and they vary. Some are very bottom line focused, and unless there's no insurance or no other way, they will look for. We'll see.
Looks like there's one last question. Sarah asked, why doesn't traditional, quote, traditional chemotherapy work for MTC, newly diagnosed?
Good question. Uh, and the answer is I don't know. But one of the thoughts that we have had, we have done some work on a gene called ATF4, and ATF4 is a very important gene because it directs entry into the cell death pathway. And what we have shown is that activating mutations of RET downregulate ATF4, and therefore cells don't die. And as you look at standard chemotherapeutic agents, there are several mechanisms of action. One in which cells that are proliferate, that is, divide, their DNA division mechanism is disrupted, and as a result, they die. Well, in medullary carcinoma, it's a very slowly growing tumor. And if the cells are not dividing while the patient is receiving chemotherapy, there may be no effect. And the other is that some work by activating the death pathways, in other words, forcing the cell into a death pathway. Well, if the entry point to that pathway is downregulated, you can't die. And that's sort of our thought process about medullary carcinoma. As you look at it, it can remain stable for decades. And it slowly accumulates, and it's more a pattern of the cells don't die. So that's my simple-minded thought process. And but I think the truth is we really don't know.
So I just wanted to be sure to thank ThyCa and Gary Bloom and all of those who have contributed so much to this this virtual conference. All of our attendees. I mean, you guys are the real heroes living through this disease on a day-to-day basis. We are always here for you to answer questions. My email is mzafereo@mdanderson.org, and Bob. Dr. Gagel mentioned his email earlier. Gary or any of the ThyCa team have any comments before we close?
Just like to say thank you. Greatly appreciate your contribution as always, and it's a pleasure to see you both. Keep staying healthy and safe.
Great, great.
Well,
So
thank you all.
one anonymous attendee, we'll make this the last question. Says the watch and wait is very anxiety inducing. For me personally, it feels like this method just allows it to set up shop. When will these meds become available to low persistent to prevent it from suddenly exploding? You have an answer to that, Dr. Gagel?
My own bias would be that we should never treat a tumor which is behaving well with a inhibitor. And my reason for saying that is that if you prevent the normal oncogenic mechanisms, tumors have a way of evolving. You remember the phrase from Jurassic Park where it says life will find a way, or something to that effect? Well, if you try to suppress cell growth or promote cell death, what happens is that you you may kill those cells that are responsive, but you then select for a more aggressive form of the tumor. And instead of living in peaceful harmony, suddenly you've got a set of cells that have a different mutation that is not responsive to the tyrosine kinase inhibitor. So until we have kinase inhibitors or a way of killing cells with something approaching 100% certainty, I would not want to use these drugs in a patient with early disease. I can only think of bad things happening. The second reason is they're very expensive, and there's not a shred of evidence that treating early at this point will make a difference. And the third is they come with side effects. And do you really want to take a drug that comes with some significant side effects for 30 years? Maybe yes, maybe.
Yeah, and I would wholeheartedly agree with that, Dr. Gagel's comments there, and that we would not want to try to create a sort of a selective pressure on these potential low risk and indolent tumors, and potentially make them more aggressive. And we don't really have data for that, but hopefully we will have long-term data in the years to come to better answer some of these questions. Well, with that, I think we will wrap it up. Thanks so much to Dr. Gagel, to Gary Bloom and ThyCa, and all of you.
Thanks, everyone. Have a good week.
Thank you.